Good morning and welcome to the Sunday breakfast session. We deal with the transesophageal echocardiography on a weekly basis under the Forum of Cardiac Anesthesiologists, Bangalore. And I welcome Dr. Rachana and Sucharita Das. Both are experts in the field of echocardiography. And Sucharita will be moderating the session, and I request Sucharita Das to introduce Rachana and then take it forward. Sucharita is a senior consultant of cardiac anesthesia at Rachana Wadhawa, Bangalore. Thank you so much.
Good morning, sir. Good morning to all dear colleagues. Today for this breakfast session, our speaker is Dr. Rachana Wadhawa. She is working as an associate professor in the Department of Cardiac Anesthesia, Department of Anesthesiology and Intensive Care at GB Pant Hospital, New Delhi. Her areas of interest has been perioperative management of patients undergoing cardiac surgery. She takes active interest in TE teaching and training. She also teaches BLS, SLS, ATLS and the trauma. She has got numerous publications, 37 articles in various national and international index journals. She has also written 5 chapters in books. And apart from there, she is also in the editorial board of Indian Journal of Clinical Anesthesia and Indian Journal of Anesthesia and Analgesia. She is certified trainer for ALS, BLS, and she has got experience more than 16 years in this field of cardiac anesthesia. You're most welcome, Dr. Rachana. She is going to present today the tricuspid and pulmonary valve assessment. These are the called forgotten valves, right? Many times we just ignore those valves, and it's very difficult to see on TV because these are right-sided valves. The mic is over to you. I won't take you much time. We'll discuss it later on. Thank you.
Thank you, ma'am, for the kind introduction. Good morning, everyone. So I'll begin with the session. There are no conflicts. Am I audible? Is the screen okay?
Yeah, you're audible and screen is perfectly fine. Please carry on.
Okay. So the objectives of this session will be like delineating the anatomy of tricuspid valve and pulmonary valve, the transesophageal echo assessment and different views for assessment of tricuspid valve and pulmonary valve, the different pathologies. I'll just touch upon the pathologies and minimally invasive procedures as well as the surgical interventions, whatever are possible in this scenario, including the guidelines. So tricuspid valve and pulmonary valves, they have been forgotten valves, but in recent era, nowadays they are from neglected to being noticed just because of the minimally invasive procedures that are likely to be proceeded in these procedures. So this is the slide showing aortic, the different relations of the pulmonary valve as well as the tricuspid valve along with aortic and mitral valve. So the pulmonary valve has got its tricuspid, has got 3 cusps, anterior cusp, left and the right cusps. The tricuspid valve also has 3 cusps. This is the medial or the septal cusp, the anterior one, and this is the posterior one. So I'll begin with the tricuspid valve first. It is the largest and most apically placed. The orifice area is 7 to 9 centimeters square. And the annulus is D-shaped. It is ellipsoid. The valve is placed in a saddle shape position. It is a low pressure gradient, that is from RA to RV, the pressure is less than 2 millimeter mercury, and the different components we will discuss in the following slides. So there are 3 leaflets, 3 commissures. This is anterior septal, this is anteroseptal commissure, posteroseptal commissure, and anteroposterior. These commissures are basically indentations. And there are 3 papillary muscles which are attaching these leaflets to the RV wall. The chordate tendina, they arise from the apex of the papillary muscles and they go up to the depth of commissures, and the multiple caudal attachments, different types of chordae, primary, secondary, tertiary, and these different multiple caudal attachments, they are important mediators once tricuspid regurgitation happens, as they impair proper leaflet coaptation in the settings of RV dysfunction and adverse remodeling. Normal tricuspid valve area is 7 to 9 centimeters square. Just elaborate on the papillary muscles. The three papillary muscles are anterior, posterior, and septal. They exhibit variability. The anterior and posterior papillary muscles, they are largest. Anterior papillary muscle, we can see here, and the septal one is the smallest. Septal wall or small septal muscle, it is chordae. It may be like a septal small cusp at times. The anterior papillary muscle connects the septal muscle via the septo. I think this is very important, especially whenever there are RVOT obstructions, that the anterior papillary muscle, it connects the septal muscle via the septomarginal tubercle. So this is known as moderator band, and it carries a twig of right bundle branch, and it also aids in deflecting the bloodstream from inflow to outflow view. Now, highlighting about the tricuspid annulus, it separates the right atrium from the right ventricle. It is less fibrous than other annuli. The normal diameter is say 28 plus minus 5 millimeter. More than 4 or less than 1 is considered more than 4. It is like diagnosis of annular dilatation and may lead to tricuspid regurgitation, and less than 1 is considered to be indicative of tricuspid stenosis. The normal tricuspid annulus is saddle-shaped structure. It is non-planar with the highest points in anteroposterior, highest points in the anteroposterior direction, and these are the lower points. In patients with functional tricuspid regurgitation, the annulus dilates along the RV free wall and it becomes more circular and planar. So mean maximal TA circumference and area in healthy persons is the circumference. This is the circumference, and the area is pi r square. And if the circumference is more than 12 and the area is more than 11 plus minus 2 centimeters square, this may lead to functional tricuspid regurgitation. One very important part of the anatomy is conduction system associated or alongside the tricuspid valve. It is located near, this is the septal leaflet. It is located here. We call it as triangle of Koch, and this is tendon of Todaro. It serves as anatomic landmark for AV node. So AV node lies in the apex of this triangle, which is bounded by septal leaflet. Anteriorly, this is septal leaflet, the tendon of Todaro posteriorly, and central fibrous body. This is the coronary sinus. This is the coronary sinus. This is placed inferiorly. Consequently, if suppose the surgeon is not very careful, so if and he's taking the sutures somewhere here, this may lead to complete heart block. So that is why the De Vega's repair and the C-ring that we use, this will avoid this kind of area to avoid the heart blocks. Is tricuspid valve really tricuspid? There are two studies which have actually redefined these tricuspid valvular structures. And Kawada et al. They found in 27, the posterior leaflet had 2 or 3 scallops and the posterior leaflet had 1 or 2 indentations, which can be mistaken for true commissures. Annulus of the posterior leaflet was significantly longer than the annulus of the other 2 leaflets, and it was supported. And in the another by Sunita et al., they showed that single leaflet was present in 6 hearts, double in 26, triple in only 4 hearts, and anterior leaflet larger with multiple scallops. So if it is seen like very intense meticulously, so a number of people, we will not find that tricuspid valve is actually tricuspid. So what are the different views to assess the tricuspid valve? So we've got mid-esophageal 4-chamber view, RV inflow-outflow view, modified bicable view, 5-chamber view. Then we've got transgastric basal short axis view, RV inflow view, RV basal short axis view, transgastric RV inflow outflow view, and deep transgastric RV inflow outflow view. So I'll be discussing all these views one by one. And what we need to see is we will see all the valve leaflets. It is very important to rule out whether if there is any organic disease of the valve leaflets, because that will decide the surgical decision. If suppose there is pathology of the valve leaflets, they will never coap properly. So it is very important to delineate the anatomy of the leaflets, their number, size, shape, if there is dooming, there is prolapse, there is flailness of any segment, thickness of the leaflets, mobility, calcification, how is the annulus, how is the subvalvular apparatus, and then the assessment by CW color Dopplers, by continuous wave and the pulse wave. So these are the four basic views described by Kaplan. This is the four chamber view. What is important is that we will see that in the four chamber view, we will have anterior or posterior leaflet here, and this is the septal leaflet near the interatrial septum and interventricular septum. This is RV inflow outflow view. This is one of the best views to have the idea of the tricuspid valve. And on the lateral side, this is the posterior leaflet, and alongside this, the medial part is the anterior leaflet or septal leaflet. Then we go to bicaval view. This view is very good for the color wave Dopplers, for the continuous wave, for the pulse wave, just because of the alignment of the Doppler and the assessment of tricuspid regurgitation. This is transgastric view at the angle of 135 degrees. Here we can, this is very good view having both the tricuspid valves and pulmonary valves, though it is not so easy to obtain this view. So coming to the first view, mid-esophageal four-chamber view, this gives us a lot of idea about the RV, about the tricuspid valve, the annulus, the septal leaflet, the anterior posterior leaflets, the mobility, and the overall assessment of the tricuspid valve can be done through mid-esophageal four-chamber view. So this is mid-esophageal four-chamber view. This is severe MS with primary or secondary TR. Now, this is severe MS. We can see that because of this, there is spontaneous echo contrast in the LA, and this has led to severe TR. This is again severe MS, and there is severe, must be severe PAH leading to Now this is mid-esophageal four-chamber view having Epstein's anomaly. In this we can clearly see the atrialization of the right ventricle, the septal leaflet, and the length of the anterior leaflet having severe TR, So in the four-chamber view, it is very good to measure the annulus, and if this annulus is say more than 40 millimeters or more than 21 millimeter per meter square, if this is indexed is more than 21, then that is a surgical indication for repair or replacement. Now we come to RV inflow outflow view. So if we turn the probe to 50 to 60 degrees from the aortic valve short axis view, we will have this view. This is aortic valve seen in short axis. This is LA, RA, and this is the tricuspid valve. This is the RV, RVOT, pulmonary valve. This is the anterior and this is the posterior cusp. So this is the RV inflow outflow view. In all the tetralogies, in all the pulmonary valves, this is also known as wraparound view. This is also known as wraparound view because the PA catheter, it wraparounds this aorta. This RV inflow outflow, it just looks like that it is wrapping around aorta. So this is one of the good views to have both tricuspid valve, RVOT, and the pulmonary valves in single view. This is mid-esophageal modified bicaval view. So this is the SVC, this is the IVC, this is the tricuspid valve. So this view is very good for the color Doppler, for the continuous wave, just because the Doppler is very well aligned in this view. So just a still showing this will come from once we move the angle from aortic valve short axis view to say 110 to 120 degrees, and we will have SVC here, IVC here. This is the right atrium, right atrial appendage. This is the interatrial septum. One of the very good views to see the PFOs, the ASDs. This is LA, and this is the tricuspid valve. So this is the view. This is taken at 120 degrees, and this is the view showing severe TR, severe TR. So this is very important for the estimation of PA pressures for right ventricular systolic pressure. So we've placed the Doppler line here, and this is the continuous wave Doppler, and estimating with the velocity, say the pressures, the RVSP will be 4V square plus RAP, and here we've calculated. So TR velocity was 2.84, gradient came out to be 32.3. If we measure it with add on RAP, so this will give us value of RVSP. So this is mid-esophageal 5-chamber view. So here we will have the septal or the anterior cusp over here. So we'll be able to see this cusp over here. So this is transgastric RV inflow view. So in this, the multiplane angle is rotated to 100 degrees until the apex of the RV appears on the left. It displays the posterior leaflet and the anterior. So this is the RV is coming like this. This is the posterior leaflet and this is the anterior leaflet. And so this view is very good for the assessment of the subvalvular apparatus. So here we can see this is one leaflet, another leaflet, seeing the cavity of the RV. Another thing that we may find in these pathologies, if there is associated lesion is severe MR, TR and RV dysfunction, there will be hepatic venous systolic flow reversal. This can be seen here. So transgastric RV inflow view. In this inflow view, the best part is that we will, this is the only view, it will image the anterior, that will tell us about the right ventricular walls. We will have inferior complete free wall and this is the anterior wall. So this tells us about the papillary muscles, the chordate tendina, and the posterior leaflet is seen here. So transgastric RV inflow outflow view, this is seen at 100 and 100 degrees. And this is the posterior leaflet, this is RA and this is the RV, and here we can see the anterior leaflet. This is transgastric basal short axis view, and this is the only view where we will have all the three cusps, though it is not so easy to obtain and not so easy to visualize these three. But then this, once we obtain this view, so we will have all the three cusps simultaneously. And the septal leaflet is closest to the LV, as we all know, and the posterior is in the near field and the anterior one is in the far field. So now if we have to quantify the severity of tricuspid regurgitation, so the AHA-ACC guidelines, they have given us for the assessment that we have to assess the central jet area, continuous wave Doppler, the jet density and contour, the hepatic venous flow. If suppose density is less, the regurgitation is less, hepatic venous flow, systolic reversal, hemodynamic consequences of TR. What are the sizes of RV, RA, IVC, and the RV functions? So this is basically the etiology of tricuspid regurgitation. We may have primary because of Epstein's, carcinoid, rheumatic, or secondary is generally common because of left heart disease, because of PAH, because of atrial fibrillation. And in the pathophysiology, it is increase in LAP or pulmonary hypertension that will lead to RV, subsequently RV dilatation and dysfunction, tricuspid valvular annular dilation leading to tricuspid regurgitation. So these are the different views. This is the 3D, three-dimensional view obtained by 3D-TE. This is being seen from the RA site, and this is aorta. This is interatrial septum. Behind we've got coronary sinus. This is the septal leaflet. This is the posterior, and this is the anterior. The different views measuring. This is measuring tricuspid annulus. This is measuring right ventricular volume, and this is measuring the regurgitant jet area. Now, accepted cutoff values for non-significant right-sided chambers enlargement is mid RV dimension less than 33 millimeter and diastolic area 28 centimeter square and systolic area less than 16 centimeter square. And if suppose the fractional area changes more than 32-33%, then this is indicative of severe TR. So this is how we can calculate the effective regurgitation volume and effective regurgitation flow. So if the regurgitation flow was, this is calculated from PISA 2 pi r square into arising velocity. So effective regurgitation area in this, after seeing the colored wave Doppler, these were the values. The arising velocity was 32 centimeter per second, and this was jet VTI, and this was peak TR velocity. So effective regurgitation orifice area can be calculated by this PISA. We calculated pi r square divided by peak TR velocity. So this was the regurgitant orifice area. And if we want to know the regurgitant volume, we can calculate by area into the VTI. This will give us 44 ml. So this is the effective regurgitant volume derived by continuous wave Doppler at tricuspid valve. The indirect parameters will include the abnormal frail or large coaptation defect when the tenting area is more than 1 centimeter square. IVC generally seen in bicaval views and if the diameter is more than 21 with 50% collapse, and the eccentricity index can also be calculated, which is calculated by longest right lateral distance. That is, we connect the RV longest length and the distance from the RV free wall to the ventricular septum. Then there is another parameter, early inflow outflow index. Emra Ekar et al. They showed that these are the independent predictors like right ventricular early inflow outflow index of more than 10, VC width more than 0.7 centimeter, and TR jet area more than 10 centimeter, and effective regurgitation orifice area more than 0.4 centimeter, area of severity of TR, and their correlation with the mortality and morbidity. Additional echo measures in TR will be evaluation of RA volume, the functions and dimensions of the right ventricular, estimation of the right ventricular systolic pressure we've already done. And now when to intervene and how to intervene. If suppose the severity, if it is severe TR and the patient is being operated for left-sided lesions, then the TR will always be touched upon. And most of the times it is repair if the leaflets are normal, and if there is any organic pathology of the leaflets, then at times replacement is required. So it is very important to know if the VC width is more than 0.7 centimeter square, regurgitation orifice area is 0.4 centimeter, and volume is more than 45 ml, then it is the time to intervene. So Kaplan clearly says that if it is like progressive functional TR, so it begins with stage B. There is no stage A in tricuspid regurgitation. So if there is a left heart surgery and if it is like severe or symptomatic, it has to be touched upon. And even if it is mild to moderate, it will be, the intervention will be done. So surgery is indicated in patients with severe primary, this is AHA guidelines, primary tricuspid regurgitation undergoing left-sided valve surgery, and even in the symptomatic patients. So this is the De Vega's repair. I told you this is the area which has to be left free to avoid the conduction blockage. This was severe TR, and this is how the de Vegas has been done. This is the HT. So the conundrum goes from like it has been named as massive and torrential depending upon the effective regurgitation orifice area and the regurgitation volume. So torrential, if it is like more than 80 millimeter square, regurgitant volume is more than 75 ml and VC is more than 21. So this is known as torrential. Tricuspid stenosis is uncommon. It is more common in females than in males, and it is usually rheumatic. It can also be seen in tricuspid. And what we need to remember when we come to tricuspid stenosis is if the valve area is less than 1 centimeter square, there are evidences like enlarged right atrium, the patient is having symptoms, and the mean pressure gradient is more than 5. T half is more than 190. And inflow time velocity integral is more than 60 centimeter, then this has to be touched upon. So still a lot of work needs to be done with respect to tricuspid valve. I'll quickly go through the pulmonary valve. Yes, the pulmonary valve, I've already shown you that it is the smallest valve and it has got 3 cusps, anterior, right and left. And though it is semilunar, just like aortic, but the leaflets are thinner. It is most difficult to image by most techniques due to its position between the right ventricular outflow tract and the pulmonary artery. And nowadays there is resurgence of interest just because of the percutaneous interventions. So the challenges is the distance from the transducer, T probe, the complex anatomy and morphology of the pulmonary valve and the RVOT. Here also all the 3 leaflets are not visualized by 2-dimensional echo, and pulmonary valve visualization is often suboptimal using standard TE imaging windows. And here epicardial imaging is found to be superior. So assessment also similar to LVOT, there is subvalvular area, valvular, supravalvular tissues, and pulmonary valve is mostly involved in congenital heart diseases. So it may be associated with tetralogy and other where we have other pathologies of cyanotic congenital heart diseases. Pulmonary valve lies in the middle of the RVOT, and we have to assess the leaflet presence, motion, integrity, masses, and the supravalvular and subvalvular tissues. They have to be looked into thoroughly, and it is very, very essential to see them. So what are the basic 4 views with which we can actually analyze the pulmonary valve? These are RV inflow outflow view. This gives a very good view of the pulmonary valves, of the infundibular stenosis, of the infundibular picture, subvalvular areas, supravalvular areas. And this is one of the basic crunch where we will definitely would like to look at the RVOT and the pulmonary valve. Mid-esophageal aortic valve short axis. Withdrawing the probe from here will give us the pulmonary artery view, the branching of the pulmonary artery, the RPA, the measurements of Nakata's index for the operability of TOF, and upper esophageal pulmonary valve long axis or aortic arch short axis view. I think this is the view we all see for patents for PDA, patent ductus arteriosus. And if we go to the, I'll just come to it subsequently, and then we've got transgastric pulmonary valve view by rotating the angle to 110 to 140, generally around like 130, 132 degrees. So this is mid-esophageal aortic valve short axis view. Here we see the pulmonary valve. And this, once we move the angle to 60 degrees, we have this opening of the tricuspid valve and pulmonary valve. So this is inflow and outflow view. This is the position of the probe. This is for all the juniors and beginners who have joined. So this is the aortic valve short axis view. We can see 3 cusps of the aortic valve. This is tricuspid. Was just trying to highlight the pulmonary valve over here. This is mid-esophageal long axis view. This is the interventricular septum. Here we can see the pulmonary valve. And this patient had significant infundibular stenosis. So we can see the turbulence over here in the RVOT. So this is the view upper esophageal. I'll just show you the next. So what we do is we rotate the probe and we have this view of the descending aorta. We just keep on withdrawing the probe till this becomes aortic arch. Then at that point of time, we will make the angle from 60 to 90 degrees so that this pulmonary picture comes in view. So this must be the pulmonary valve. This is the best view to have the continuous wave Dopplers for having the estimation of the gradient across the pulmonary valve. So this is the aortic, this is the ascending aorta basically when we've come to the aortic arch, and this is the PA, this is the RVOT, and this is the pulmonary valve. So here we can see the pulmonary stenosis, the regurgitation, we can have the gradients here pre-operatively and post-operatively. So pulmonary regurgitation, I just quickly finished, it's 9:30. So pulmonary regurgitation, it is seen in normal hearts in the patient in over 30%, and studies have demonstrated that more significant pulmonary valve regurgitation may lead to progressive RV dilatation and dysfunction, especially with increasing age. And that is why it has to be addressed, just because it may be associated with sudden cardiac death. Most common causes of PVR is pulmonary hypertension, but it is most common after surgical or percutaneous procedure for pulmonary valve stenosis or repair of tetralogy. Congenital bicuspid or quadricuspid valves of the pulmonary valves, carcinoid heart disease, rheumatic heart disease, infective endocarditis, connective tissue disorders, and syphilis. These are uncommon causes of pulmonary valve regurgitation. So what is important is the evaluation of the pulmonary valve, the RVOT morphology, the presence and severity of regurgitation. The complex RV geometry is further distorted by previous surgery, and this limits the complete assessment. Using 3D, if we are using 2D, we have got only two planes. But if we've got 3D transthoracic or transesophageal, that is the best way for the assessment of the pulmonary valve as well as tricuspid. But for the pulmonary valve, it is very, very essential. Because 3D echocardiography, color Doppler allows positioning the cropping plane to exactly parallel to the vena contracta, and then it can be planimetered accurately. So the 3D methods have been found to be quite superior to the 2D methods. So if we have to say comment on the severity of the pulmonary valve regurgitation, then if the jet density is has got good density, the vena contracta is more than 6 millimeters, the color Doppler jet width is more than 50% of the RVOT width. pH pressure half time is less than 200, and the regurgitant fraction is more than 50 to 60%. The diastolic flow reversal in pulmonary artery, it is hollow diastolic flow reversal, and the secondary findings of SVC, IVC dilatation, right atrial enlargement, right ventricular enlargement, severe RV dysfunction, or tricuspid regurgitation, then they all indicate towards severe pulmonary valve regurgitation. Pulmonary stenosis, it is also described as lesion associated with RVOT obstruction. What is important is that it may be subvalvular, valvular, or supravalvular. And assessment of pulmonary stenosis or subvalvular, valvular, supravalvular level, it is very, very important whenever we are operating the patients of tetralogy. So we've got different kind of windows. I'll just come. This is pulmonary valve endocarditis. Yes, this is also quite seen if though it is like undiagnosed or underdiagnosed, just because after interventions the chances of pulmonary valve endocarditis increased. So it has to be looked upon, and it is generally missed because of low clinical suspicion and limited echo views. Miranda et al. It showed diagnostic accuracy of pulmonary valve endocarditis with transthoracic to 62 and with TE with for up to 57% only. So once autopsy was done, 50% of the cases were missed by 2D echo. So we've got carcinoid disease, we've got pulmonary valve fibroelastoma, and these are the features that we may have to look into to rule out if any intervention is required on the pulmonary valves. So what is upcoming is percutaneous pulmonary valve implantation and improvement in treatment of congenital heart diseases over past decades, and it has enabled more children to survive well into adulthood. And this is one of the most innovative procedures to develop the treat the congenital right heart disease in the last decade. So it is minimally invasive transcatheter based approach to prolong the conduit life by treating stenosis and regurgitation without the need for open heart surgery. So it eliminates the surgical risk and the hospital stay. Expanded experience with live or real-time 3D transesophageal echo has led to the appreciation of its utility for accurate evaluation of RVOT anatomy and guidance for successful percutaneous pulmonary valve implantation. My limitation is that I don't have 3D transesophageal echo working presently at my place, and so I did not have the 3D images, but still I would like to highlight the importance of the 3D transesophageal echo, especially when it comes to the pulmonary valve root evaluation. And as 3DT has become a part of our trans of transcutaneous transfemoral aortic valve replacement, so its utility in PPVI is also increasing, and but still, despite being less invasive, it still has complications like device migration, stent fractures, coronary compression, severe PVR, and infective endocarditis. And 3D echo plays a very, very important role in early detection of complications and in decision making. It has the potential to become the standard procedure in the treatment of dysfunctional RVOT conduits and pulmonary valve disease. And 3D offers the spatial resolution and continues to enhance image quality, but it also has technical challenges because of the limitations in acquiring all images. And acquisition is difficult in pulmonary valve because there is signal dropout from the thin leaflets. While 3D echo is routinely used in clinical practice, there remains no guidelines to direct its routine use and standardization for the evaluation of this process. So comprehensive imaging of the pulmonary valve still remains challenging, and 3D echo would have been the best tool for increasing its utilization in PPVI. So this is deep transgastric view having tricuspid and pulmonary valve in place. This is again showing the turbulence in the RVOT. This is again showing the these are RV inflow outflow views highlighting the pulmonary valves and their. So this was done pre-operatively as well as post-operatively to have just because this patient had infundibular stenosis. So the images were obtained pre-operatively as well as post-operatively to rule out all this. So now to conclude, the pulmonary valve as well as the tricuspid valve, they have got highly variable anatomy. Tricuspid valve is really tricuspid. It can both have to be assessed. There is no single view that can tell us about any pathology, especially when all these three leaflets, they're not seen in single view. So we've got different views. It is a combination of different views, qualitative and quantitative assessment to derive at a diagnosis, to derive at a conclusion. And for the pulmonary valve, so in 2020 ESC guidelines, European Society have given the guidelines that if there is pulmonary valve regurgitation and there is no native flow track, catheter intervention should be performed if anatomical feasible. And it has the replacement has to be considered in asymptomatic patients with severe pulmonary regurgitation or right ventricular outflow tract obstruction in the presence of progressive RV dilatation to RV end systolic volume more than 80 and end diastolic volume more than 160, or progression of tricuspid regurgitation to at least moderate. So this is the class 1 recommendation specifically for the pulmonary valve given by the European Society. Thank you. Thank you for your patient hearing.
Thank you, Dr. Rachana. It was a wonderful talk. You started with anatomy. You have told us how the leaflet position changes as we go in the different multiplanes. And you have rightly mentioned how all those debakers and all can cause the conduction blockage. Many times we forget to get the pacing box in the operation theater. So I'm sure it is one of the important aspect that we got to know. And yeah, I'll just first take that any question has been there, then we'll go into discussion further. I can see the chat box is completely empty. If any question, please come ahead.
Was I audible?
Yeah, it was a very wonderful talk and it was audible and it was very clear. Like, what we need to see, how
this is like a basic kind of thing. I did not touch upon the complicated calculations.
Yes. No, that was wonderful. Yes, there's anything. Chat box has been like what is my right
Good
side?
morning. Good morning, madam.
Yes,
Good
please.
morning. What is torrential tear? What is the when you address the tear with the valve? Is there any role of as you told percutaneous?
So what I could find was that this conundrum has been given, but if it is having any role in surgical decision making was not clear. Means they have given this just because of massive people used to have how much tricuspid regurgitation is there. So even with severity of tricuspid regurgitation with left-sided heart lesions, surgeons, they think that they have treated the left-sided heart and they don't touch upon the tricuspid regurgitation. But if it is like torrential tricuspid regurgitation having this much of regurgitant volume, so and they have already opened the heart, they are already replacing other valves, so they must address this. So this conundrum came into practice after that. But I think despite all this conundrum, it is like surgeons and if the pathology is like all right, we must go for repair. And I could not find any difference in surgical decision making with respect to all this, but then they have given this conundrum.
One more thing, as you have said that left side, whenever there is a left side valve involvement and patient has got a severe tear, you have to basically touch on the tricuspid valve. Is there any correlation with hypertension? Like is there anything only that indexed like annulus surface area, what we do by 2.2 or the tricuspid annulus around 40 millimeter? These are the two we take. Is apart from any other parameters do you look into?
Ma'am, yes, we look at RV volumes, and I think this assessment of RV volumes, we are doing it regularly. We are actually trying this just because I don't know, means the patients nowadays are where we are leaving this severe tricuspid regurgitation, they do come back with CHF. It is not that we've treated the left side of heart and the right side will automatically be treated. I think 50 to 60% must be benefited if there are not significant changes. But once the RV geometry changes and the annular dilatation is to that extent, and we've not done anything, so the patients may turn up, and 20 to 30% is the incidence, and I think it is a big incidence. Means once the patient has been operated, and out of 100, 10 patients they come up having some problems, symptomatic problems. So I think we must look upon this.
Yes, like not only the annulus diameter 40 or maybe the
we are
index
seeing
cannot
all
be.
we are estimating all the volumes.
Yeah, even say that if the pulmonary pressure is in more than 33, it goes. So there are some studies which says that should be addressed, or some papers it is then diastolic RV and diastolic diameter more than 40, then also it comes one of that. So these are also been taken into look into, so these are the parameters also been important. And one more thing is a pulmonary valve, that annulus is not being attached to the fibrous ring. It is just directly attached to the muscle, RV muscle, right?
Yes.
So when the Ross procedure and all, we have to assess the pulmonary valve. So on
Yes.
those cases, definitely difficult to measure the annulus. So because it's not the fibrous ring, right? Directly attached to the RV
Here
muscle.
the role of 3D comes. Recently, we
Yeah.
got a ROS.
So there the
So
3D probe comes
it
in.
was successful. It was our ROS was quite successful. I think few days back only a
Yeah.
ROS procedure was done.
Yes.
But then we also had challenges actually. Means
Hmm.
all those just because I think the surgeon was good, there was some mismatch of the
Okay.
size and still they managed to place it. But then I think the 3D images we have acquired the machine and it is in the process of installation.
Yeah.
So 3D will definitely have a better assessment
Yes, for the
and
right-sided valves,
it is
definitely.
better that replacement and outcomes will
Yes,
definitely
yes,
improve, ma'am.
yes.
Yes,
That is.
ma'am.
Munizar sir.
Rachana, very nice presentation, very
Thank
well
you, sir.
done. There are two attendees have raised their hands, and there's one
Okay.
question in the chat box.
Yes.
Yes, sir.
Can you unmute them and ask them their
Yes,
question?
yes, please, sir. Whether I can have their questions, sir.
Yes, sir.
Please.
Yes, sir. This is Dr. Pavitra. Good morning, madam.
Good
Madam,
morning.
I have a question. This
Yes,
is after post repair of tricuspid valve. What is the
yes.
accepted transvalvular pressure gradient? Normal.
Ma'am, if suppose you've done the repair or the replacement,
After repair, ma'am, when left heart valves are involved, during that time when we are addressing the tricuspid with repair, what is the accepted tricuspid valvular pressure gradient, ma'am?
though in the literature we have not found, but repair is done usually. And if suppose it is like more than 5 to 6 of mean, then we have to see if the surgeon should not create stenosis. So that is one of the most important thing. And there are 2 3 things that we need to see. We will check the annulus once again, though there are no cutoff limits, but see the change despite doing the correction then and there, the gradients may not change significantly at that point of time. So it may take some time for the change of gradient. So we do look at the gradient. If suppose it is like more than 5 of mean, we will definitely tell the surgeon that this is the case. And if at all the surgeon also thinks, the surgeons know what they have done usually. So if at all he thinks, then once the surgeon he did went back because the gradient was like more than 8. So but if it is suppose less than 5, we carry on with that. This is my practical, but theoretically I could not find any data with respect, because I searched it at that point of time that what should be accepted. I don't know, sir, if Mulidhar sir can comment. This is what we are doing practically.
Yeah, the transvalvular gradient of more than 2 to 3 may be indicative of stenosis in tricuspid valve. In the mitral, it is 5 to 7,
Yes, sir.
but in the tricuspid, it is lower because of the low pressure nature of the right-sided chambers. So more than 2 to 3 must be considered. You must pay attention to that and see whether it has to be readdressed or it can be left alone.
Yes, sir.
In mitral, it is 5 to 7. Up to 7, we can accept. But here it is less. 2 to 3 is what we
Sir,
can.
it's a five, sir. It's a 5. It's a 5 in the tricuspid and 8 to 10 in the mitral. What if?
The theory says it is 5. Yes, sir. It's okay. Means because at times it will take some time for this. The pressure do they change with passage of time even after surgery.
Sanjeevani, you have anything to say on this?
Hi, good morning. Very nice discussion. And are you able to hear me?
Yeah, we
Yes,
can
yes,
hear.
yes, ma'am. It's audible.
Yes, this is a tricuspid stenosis is difficult to quantify, And I think 5 is severe tricuspid stenosis. But
Yes.
as Dr. Muralidhar says, to be on safer side and being a low pressure system, 2 to 3, one should, because in during surgery it's a vasodilated situation sometimes, blood pressures are low. So it is always wiser or prudent to accept less than 2 to 3 rather than going up to 8 is to very severe stenosis, no doubt about it. And these are all mean pressures, mean gradients.
Yeah, this is mean. This is
Mean
mean, of
gradient.
course.
So what Prabhu is saying, yes, that is given in textbooks. Okay, but during intraoperative scenario is totally different. And tricuspid stenosis is difficult to manage also. So it is better to accept 2 to 3 rather than 5.
Okay, thank you, madam. Thank you, sir.
Any more
Hello.
further questions?
Good morning.
Yes.
Yes, yes.
Yeah, good morning, ma'am. It was a wonderful presentation. I have a small doubt, ma'am. Multiple studies have been conducted regarding the multiple leaflets which are seen in the tricuspid valve. It is like no more a tricuspid, like with a tricusp. So, how do you differentiate between a scallop and a leaflet, ma'am?
The scallop and a leaflet. So this is the study which they had conducted was an autopsy. Okay, Sunita et al. They had done autopsy, and the volume, the sample size is also very less. But they found that only 4 hearts had tricuspid valve. So the valve morphology is with the attachment of the RV free wall with the chordate tendon. Okay. So, and there are different the commissures, and if the commissure is not there and there is just a groove on the cusp, so those are all these scallops. In the echocardiographic view, at times you will not be able to appreciate all, especially in all these low flow chambers, especially in the pulmonary valve or in the tricuspid valve. Okay. But in the aortic valve, like, it is very clear whether it is bicuspid or it is quadricuspid or it is monocuspid. Okay. But they found it in the uh, autopsy findings, not on the echocardiographic picture.
So, Madhu, do you presented a paper on tricuspid valve anatomy in Indian subjects? What were your findings in that?
Yes, sir. We have recently conducted a study in Narayana on tricuspid valve. So there we have studied multiple leaflets of tricuspid valve, ma'am.
Yes. I
Yeah,
think I
so
heard your presentation when
Yeah,
I
yeah.
was
She
there in
has
the
said it is
conference.
no more a tricuspid. I remember
Only
I heard your and
50%
I
is
could
the
yes,
correlate.
tricuspid.
there are many.
Yeah, I heard your presentation there. I could correlate that point of time only.
yes, ma'am.
Yes.
But Madhu, I just wanted to ask you, Muralidhar, can I ask
Yes, yes, of course.
is this nomenclature or whatever multiple leaflets or less leaflets, does it affect the clinical scenario?
No, ma'am.
If you're planning a transcatheter intervention,
Mm-hmm.
we must know the exact anatomy.
Okay.
It becomes vital if you're doing a transcatheter implant. That's how it came into, people are discussing about it. Because if you are addressing TR using interventional technique, we should know exactly how many leaflets are there and where is the problem in the leaflets.
Right.
Sir, it is like
Yes.
aortic valve only, sir. Anomalies of aortic leaflets. Bicuspid also might leads to pulmonary stenosis, like that. Because
No, it's much
tricuspid
more
means
than that. This much more
yes,
than that, because this is not studied in detail. Now, investigators are looking at tricuspid valve with more interest, because the transcatheter procedures are becoming common. So we need to have a complete description of the anatomy in a given patient. Only then we can attempt transcatheter device or whatever procedure. You are putting a clip or
Right, sir.
doing any repair work, you should know what's the leaflet anatomy.
Madam, Epstein's also same indications for repair or this one replacement. What you told, Dr. Rachana,
Epstein
madam.
is, it is like totally different pathology. Okay. I really don't think that we actually don't correlate that with only TR. There are so many features associated with Epstein's that the surgical indications, they have to be like focused not only on tricuspid regurgitation but also on the atrialization of the right ventricle. What is the functional right ventricle which is left?
Yeah.
So I don't think that it is alone the tricuspid regurgitation, because the septal may be redundant and the anterior will be very long coming down. So tricuspid regurgitation is just a part of it, and we have to address Epstein's, seeing n number of factors, echo also, the symptomatology also, age of presentation, associated features, and the surgical conundrum of Epstein is slightly different, uh, not only focused to tricuspid regurgitation, as I discussed. It was showing a part of tricuspid regurgitation, but you may be knowing better. You must have got operated so many Epstein, so it is not only tricuspid regurgitation. This is like functional RV, the utilization of RV associated so many anomalies, and that would lead to the indications of Epstein's, the bundle branch blocks, the rhythms associated with the Epstein. There's so many factors associated with Epstein.
Murlidhar, can I?
Yes, please. Yes, please.
This number of leaflets of tricuspid valve,
Yeah.
this can also, I mean, no, I don't think anyone has studied it, but it isn't it important for CRTD and pacemaker implantation also? Because sometimes it may go through one of the small leaflets and cause the dysfunction of the.
Normally, when we insert pacemaker wires and these devices which control the cardiac rhythm, we don't bother with the tricuspid valve, but it's a presence of these wires going across the right atrium to through the tricuspid valve in the RV may be a cause of tricuspid regurgitation,
Yes.
which may be significant in some patients. Other than that, tricuspid valve anatomy itself, I'm not sure that is going to lead to specific problems. I think in our study, up to 55% of the patients had three cusps of the tricuspid valve, and the remaining had 4 or 5 cusps. And also, when we replace the tricuspid valve, tissue valves are preferred rather than mechanical valves, because with mechanical valves in tricuspid position, the incidence of thrombosis is much higher.
Very high.
And the
Like
other thing
slow in
is,
Indian population.
yes,
And
So
it's
I
not been
think,
that common. Tricuspid replacement is not been that common. Like we don't do that.
it's not common.
but
Just
it
in
is
case if
being
you
done.
need to
It
do
is not
it,
like we have never
Yeah,
got that case done.
but we do it, but it's not been that common. You just try to do repair more than the
repair is more preferred than
more preferred than because of all those
replacement.
reasons only.
Yes, ma'am.
Yes.
And talk about tricuspid ring, that is also commonly done, annulus ring.
Huh.
Yes.
Yes.
Uh,
Any more questions?
If
You
there
are
are no,
in
yeah.
mitral this one pulmonary this valve replacement, even the QRS complex they have taken into consideration, one of the indications prolonged QRS.
Yes, sir.
How do you correlate with that? Is there any prolonged QRS means any blocks or anything like, or decreased RV functions?
Yes, so if there is RV dysfunction, then we must go for
Definitely, yes.
interventions if there is severe RV dysfunction. But specifically to QRS pathology, I don't know how to correlate with that.
Can
Yeah, tell me.
no, I am asking another question to Rachana. You talked about RV eccentricity index.
Yes, ma'am.
You talked about RV eccentricity index. What is it?
Ma'am, when we measure the RV length, that is like from septum to apex, and the other is from free wall to the septum. If it is like more than 2, means obviously the geometry of the RV along with the size.
And which view you measure this in which view?
Ma'am, 4-chamber view.
Chamber.
Yes, ma'am. We do this. The RV eccentricity index we are measuring RV early inflow outflow also at times. Like we do for left-sided.
Yeah, sphericity index.
Yes, ma'am.
No, actually, sorry, left-sided eccentricity index is measured for RV function,
Yes,
isn't
ma'am.
it? So I am not aware of RV eccentricity index. Murlidhar?
Yeah, it is referred to the left ventricle. So whenever there is right ventricle dysfunction, right ventricle compresses on the septum and distorts the LV shape. So there you get the eccentricity index for the left ventricle. I am also not aware of the right ventricular eccentricity. Right ventricle anyway, it is eccentric in cross section and triangular in longitudinal axis.
Very difficult to measure, and I don't know. I haven't come across this.
I will send you the slides, ma'am. I will send you
Yes,
the
yes.
Yeah, there is a reference.
I will
there
send
is
you
a reference
the related literature to this. I
Yeah,
will send
please,
personally. I will send you that, ma'am.
Yeah, routinely I think we don't use it, so maybe that's why.
Maybe it
not
is
get-
something. Yes.
Routinely we don't use
Ma'am,
it.
it is there in the literature, ma'am.
It is. Yes.
Yes, yes, yes.
We may not use it. There are many things which we do not
We don't use
do
it.
routinely,
Yes, yes,
but
yes.
yes, in doubtful scenarios,
Okay.
they are helpful.
So can I say that in RV failure, the left ventricular eccentricity index is impaired, but in RV failure, RV eccentricity index will be better.
Normal.
Yes, yes, yes. No, 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 no. The value is like
It
no,
will
it
be
is
from
right.
crescent
Value
to
is more than
crescent
2.
circle.
Yeah, it becomes circular.
So it
Yes.
is all actually the game of that septum. It is actually the game of that septum only.
It is the interdependent.
Yeah.
Always one ventricle
Yes.
leads to other ventricle,
Yes, sir. Yes.
and finally
So
biventricle.
And we
in
give
LV,
different names and different interpretations based on
Hmm.
that. And the pathology is that same only. Pathology is RV failure only.
yeah,
So,
in RV failure, the left ventricle becomes elongated,
yes, sir.
Yes.
whereas in the right ventricle becomes circular.
Yes.
Yes.
Can I say that, Sanjeevani?
Yes, yes, yes. That's what. That is why the eccentricity, if right ventricular eccentricity must be normal is 2, and then 1:1 will be abnormal. That is what I am imagining. I don't know, because it becomes circular.
We will work on this, ma'am.
Yes, yes, sure.
So that's a topic for investigation now.
Yes,
Yes,
ma'am.
yes.
Yes, sir. We must have that always. New learning and new directions.
So you have to go for the mid-esophageal 4-chamber view, is it, or not the mid-papillary short-axis transgastric view for the RV eccentricity?
No, sir. We don't measure it from that. We measure it from there only. Just because I have to see from the valve to the apex, so that will not be possible. So that's how they both are different. That's how they both are different.
Okay, thank you for that point. Thank you so much.
Yes, sir.
Okay. Is there any other question? Otherwise, we'll conclude here. Is it, sir, okay? We'll conclude?
Yes, yes. Please conclude it.
Yes. Thank you, Dr. Rachana, for such a
Thank
wonderful
you.
talk and
Thank you,
discussion.
sir, for giving me this
And for
opportunity.
even
Thank you so much.
thanks to all the participants who have been actively participated and given us a lot of input. Sanjeevani ma'am and other Dr. Prabhu. Thanks a lot, and other also been said. So I'm thanking to everyone. Thank you, sir. And
Before you conclude, I want to announce that we are starting a certificate course in critical care echocardiography
Okay, sir.
under the auspice of Indian College of Anesthesiologists and Surgeons Society and the Bangalore chapter of ISCCM. It's a 1-year course. You have to maintain a logbook of TTEs, TEEs, vascular access ultrasound, and the lung ultrasound. And there'll be weekly webinars you have to attend, and some contact classes will be there. You'll be given a certificate of critical care echocardiography.
Your talk was beautiful on that day.
Where?
No, here only on breakfast session.
I see.
COVID and echo and
Yeah.
that was nice, very nice, comprehensive.
So please, if you are interested, please let me know. Anybody interested is welcome. Okay. And TE dates for next year around 16th to 19th of August. And we'll be having a national cardiac critical care workshop in July 13th to 14th. July and August. Thank you so much.
thank you.
And good luck.
Thank you, sir.
Thank you.
Thank you.